Assalamu alaikum. Dear final year students, this is an overview of the skin diseases. I'm Dr. Sitwat. You had all these lectures in fourth year last year. And since there are some questions regarding dermatology in the medicine paper, so we always give a overview of the common skin diseases. All the slides are from the previous lectures that you've had, so they won't be new. It's just to polish your memories so that you can remember what skin diseases we did in fourth year. Okay, first of all, what is the composition of the skin? Epidermis, dermis, and the subcutaneous tissue, which includes all the connective tissue parts like blood vessels, lymphatics, nerves, sebaceous gland, hair follicle, etc. This is an LS you all have done. If you remember, ये clinical में भी मैं कराती थी हमेशा. इसमें सारी layers नजर आ रही हैं, epidermis, dermis, and the subcutaneous tissue, and all the parts of it. Then what are the physical functions of the skin? Protection, secretion, discharge, absorption, thermoregulation, sense. अच्छा ये जो lecture है, इसमें fourth year में if you remember, the histology was taken by the anatomy department, not by me. लेकिन clinical classes में हमेशा histology मैंने खुद कराई है. तो ये एक तरह से पूरा overall revision है. Layers of the epidermis. Layers from outside to inside, yeah, inside to outside. Stratum corneum, stratum lucidum, granulosum, spinosum, and then the basal layer, stratum basalis or the stratum germinativum. Appendages means जो साथ में इसके होते हैं. Eccrine gland, apocrine, sebaceous hair follicle and nail. Hair follicle क्या है? It surrounds the root. इसका जो नीचे enlarged portion होता है shaft का, that is called as the bulb. उसके अंदर होता है germinal layer, जहाँ से hair की growth होती है. और पेपिला या निपल लाइक प्रोजेक्शन होती है, वहां पे ब्लड सप्लाई होता है हेयर का. नेल प्लेट जिसको हम नेल बोलते हैं, जिस एक्चुअली द नेल बॉडी, द लैटरल नेल फोल्ड, द प्रॉक्सिमल नेल फोल्ड एंड द डिस्टल फ्री एज. जो प्रॉक्सिमल नेल फोल्ड है वो नेल प्लेट के ऊपर स्टिक होती है इन द फॉर्म ऑफ क्यूटिकल और एपोनाइकियम, राइट. And there is a half moon shaped white structure present just above the cuticle or the eponychium, which is called as the lunula. Now the lesions. The lesions are divided into three: the primary, secondary, and the special. Primary lesions are basically the reaction pattern with a definite morphology arising de novo. Secondary lesions develop as an evolution of the primary lesions or as by scratching or infection. And the special lesions are specific for certain diseases. We're going to go through these very quickly. Macules, for example, drug eruptions in secondary syphilis. Patch, a large macule, more than 1 centimeter is a patch, for example, vitiligo, melasma, pityriasis alba. Then papules, molluscum contagiosum skin tags, you can see the difference, this flesh-colored white or yellow. Plaque, for example, psoriasis, lichen planus, and tinea corporis. Nodules, you know that nodules have a body underneath the skin as well. So they're spherical and they're not just superficially elevated like a papule. So examples of nodules are basal cell carcinoma, prurigo, neurofibromatosis, hemangioma. Vesicle, small fluid-filled blister, less than 0.5 to 1 centimeter, clear fluid. Then enlarged blister and further enlarged bulla, like bullous pemphigoid and fixed drug eruption. Then pustules, small, less than 0.5 to 1 centimeter, pus-filled lesion, like in acne, pustular psoriasis, folliculitis, and scabies. Then wheals, urticaria and dermographism, intradermal edema. Then secondary lesions, scale, crust, erosion, fissure, sinus atrophy, lichenification, scar. What is a scale? Excess dead epidermal cells that are produced by abnormal keratinization and shedding. Crust, dried exudate of body fluids, which may either be yellow or red. Erosion, a focal loss of epidermis, and they do not penetrate below the dermoepidermal junction, and therefore they heal without scarring, like in tinea, candida, eczema, herpes. Chancroid basically is a type of ulcer. You can see the ulcer. It crosses the dermoepidermal junction, and therefore it results in scarring. Lichenification, repeated rubbing of the skin, results in thickening and hyperpigmentation, and the skin markings become prominent. For example, lichen simplex, atopic dermatitis. Then the special lesions or the specific lesions, for example, burrow, comedones, milia, telangiectasia, poikiloderma, purpura, and infarct. Burrow is present in scabies, It's a serpentine tunnel made by the scabies mite in the stratum corneum, and the open end of the tunnel has a papule. Scabies caused by female Sarcoptes scabiei, which is a mite, itchy papules, burrows and tunnels, interdigital cleft, axially and genitals. Scrapping a burrow is the diagnosis along with the history, and we have to treat all the contacts. Then the pediculosis or lice. Lice, itching, nits cemented to the hair and large lymph nodes. Hygiene is important and washing along with the treatment. This is all basically a revision. This is a scabies rash and the scabies mite. This is a lice. You are more familiar with this. Then eczema. Eczema is divided into the contact and the endogenous. Contact is the exogenous variety, irritant, allergic, and photodermatitis. Endogenous includes atopic, seborrheic, discoid, pompholyx, gravitational, and all. This is a picture of atopic dermatitis. You can see the child, the age, the face of the child, and look at his hands. What are they doing? They're itching and pressing lesions on the chest. This is seborrheic dermatitis, adult, ears, face, especially T-zones, eyebrows, eyelashes, all involved along with the scalp, scales. Pompholyx, you can see the lesions, the blistering present along with some pus present on the palms of this patient. Then psoriasis. Cutate psoriasis, acute onset of raindrop-sized lesions on the trunk and extremities, often preceded by streptococcal pharyngitis, more common in teenagers, completely reversible. Then inversive flexural psoriasis in the body folds, more maceration and less scaling. Then pustular psoriasis may occur as pustules on psoriatic plaques or directly as pustules, often triggered by withdrawal of corticosteroids. When generalized, can be life-threatening. Palmoplantar psoriasis, only palms and soles are involved. This can be in the form of the scaly variety, or it can be in the form of plaques with pustules over them, and often functionally very disabling. Psoriatic erythroderma, when more than 90% of the skin is involved with redness, it's called as erythroderma. Associated with fever, chills, and malaise, and the skin is not able to perform its regular functions, and hospitalization is important. Plaque psoriasis, most common type, well-demarcated plaque with overlying silvery scales and underlying erythema. Chronic plaque psoriasis is typically symmetric and bilateral. The plaques exhibit Auspitz sign and the Koebner phenomenon. Lichen planus. Chronic inflammatory disease of unknown etiology characterized by shiny, violaceous, purplish, flat-top papular lesions, morphologically and histologically by lipofactive degeneration of the basal layer and band-like inflammatory infiltrate. Typical LP, shiny, violaceous papular lesions. Koebner phenomenon, that is at the trauma site, the lesions develop again in a person who is having this disease. Lichen planopilaris, also called as the follicular lichen planus, that is the lichen planus of the hairy area, and it results in scarring or cicatricial alopecia. Oral lichen planus, lacy network. Lichen planus nails. You can see the proximal nail fold extending throughout the nail plate in the triangular form, dividing the nail plate. This is called as pterygium. Then infections. Bacterial infections include all these. Viral infections include all these. Fungal infections include all these that are included in your syllabus. This is impetigo. The left one is the bullous impetigo, which is less scaly, less scarring, cleaner, better. And the right one, on our right one, is crusted, dirty, honey-colored looking, and this is caused by streptococci, whereas the first one is caused by staphylococcus. Erysipelas, caused by Streptococcus hemolyticus. It is an infection of the skin and subcutaneous tissue with some prodrome and sharply demarcated red unilateral morphology. Cellulitis is often mistaken for erysipelas, but cellulitis is basically inflammation of the loose connective tissue. And the margins are more diffuse, not well demarcated. Red, raised hot tender lesion, bully, suppuration, and necrosis may be present. On our left is erysipelas and on our right is cellulitis. This is folliculitis, inflammation of the hair follicle, not going very deep. This is chickenpox. On the left is a complete picture of a child showing the centripetal distribution along with polymorphic picture. That is all type of lesions present in one individual. And on our right is a large magnified form showing a papule plus a blister, which is a typical finding, that is a dewdrop on petal appearance, along with an ulcerated lesion. This is herpes zoster. You can see the zostriform or the dermatomal distribution. Some of these are the cervical, thoracic, as well as the lumbar herpes zoster. Then this is measles. You can see the complex spot in the picture in the oral cavity, and the monomorphic picture in the child. You can see the lesions all in the similar state, that is maculopapular lesions. Herpes on our left is herpes simplex labialis. You can see the cluster of small vesicular lesions present on the outside of the lips. This is herpes labialis, and when it goes inside the mouth, it becomes a herpes, oral herpes type 1. It's the same virus. Then on our right is molluscum contagiosum. You can see the pearly white appearance with central depressed punctum caused by the molluscum virus. This is viral warts, the typical variety which affects the hands and feet, the filiform rough type of lesions. Then this is fungal infection. On our left is the pityriasis versicolor, which shows hyperpigmented lesions and slight itching or scaling, otherwise asymptomatic. Whereas on our right is tinea corporis. You can appreciate the central clearing and the raised active border on the trunk of a child. Then these are 4 types of the tinea capitis. The one on the top left is chirion, which looks more like an infective bacterial lesion. On just below it is Phoebus. आधा लेक्चर हो चुका था मेरा।
मम्मी पहले भी हट गए थे
हाँ,
पहले भी एक बार हट गए थे
क्यों हट गया था भाई?
पहले तो हट रहा है
रिकॉर्डिंग चल रही है तो पावर पॉइंटिंग है ऊपर। So this lecture is basically a revision of the dermatology that you did in 4th year, and it is just added so that there are certain questions of dermatology in the medicine paper, so you can go through all these lectures. Now, what is the basic composition of the skin? The epidermis, dermis, and subcutaneous tissue. I'm going to go through this very quickly because you've all done this in 4th year, and you can go through the lectures yourself as well. This is the longitudinal section of the skin showing all the layers. The functions of the skin, you all know: protection, secretion, discharge, absorption, thermoregulation, and sensory. And layers of the epidermis, the 5 layers. Appendages, the ecrine, apocrine, sebaceous glands, hair follicle, and the nail. Hair follicle surrounds the root, and it houses the germinal layer. And the bulb, the papilla, has the blood nourishment. Then the nail anatomy. You know the nail plate and or the nail body, the lateral nail folds. The proximal nail fold is extended onto the nail plate in the form of aponychium or cuticle. Primary, secondary, and special lesions divided according to the arising de novo as a continuation of the primary and specific for a particular disease. The common macules, drug eruption, secondary syphilis. Patch, enlarged macule, for example, vitiligo, melasma. Then papules like flesh-colored yellow or white, molluscum skin tags. Plaque, enlarged papule like psoriasis, lichen planus, and tinea corporis. Examples of nodules. Nodules are basically spherical with underlying excuse me, not lesions within the skin as well. Basal cell carcinoma. Vesicles are very small fluid-filled lesions. Bulla is enlarged vesicle more than 5 centimeter, like bullous pemphigoid. Pustular lesions, acne, pustular psoriasis, folliculitis, and scabies. Then wheals, urticaria, and dermographism, intradermal edema. Then secondary lesions are non-specific. Scale, excess dead epidermal cells produced by abnormal keratinization. Crusting, dried exudate of the body fluids. Erosion, superficial focal loss of epidermis and does not cross the dermoepidermal junction, so there is no scarring. Ulcer is deep, the dermoepidermal junction is crossed, so there is scarring present. Lichenification, excessive thickening, rubbing, and hyperpigmentation of the skin. And the skin markings are prominent on a background of itchy condition like atopic dermatitis. Special lesions, burrow, comedones, milia, telangiectasia are present. Then burrow is a serpentine tunnel made by scabies mite in the stratum corneum. Sarcoptes scabiei, itchy papules, burrows, and tunnels are present. Interdigital clefts, axillae, and genitals. And pediculosis, there are lice, and its itching is present. Hygiene and washing and treatment, all contacts is important. This is a scabies mite. This is a lice. This is eczema. Eczema is basically of two types, the exogenous and the endogenous. The exogenous one is irritant and allergic contact dermatitis, and the other is endogenous, which has all this variety. This is a picture of the atopic dermatitis. You have your fourth year lectures as well, so you can go through them as well for details if you want for any of these. Then this is seborrheic dermatitis in an adult involving the scalp, face, and even ears, especially the T-zones. Pompholyx affecting the palms of the soles. You can see the pustular lesions on the palms and fingers. Psoriasis. Guttate psoriasis, first type, which occurs in the teenage, often followed by streptococcal pharyngitis and raindrop type of lesions, and these are often reversible. In flexural psoriasis, then pustular psoriasis can occur on the psoriatic plaque as well as directly on the pustules, caused by steroid withdrawal. Palmoplantar psoriasis, scaly type of lesion, present only on the palms and soles and often functionally disabling. Then psoriatic erythroderma, when more than 90% of the skin is involved, affecting the skin functions as well, may be systemically affected and the patient has to be admitted in the hospital. Plaque psoriasis, most common type, salmon-colored plaque with silvery white scales, typically symmetrical, auspit sign and Koebner phenomenon are positive. Then lichen planus. Lichen planus, chronic inflammatory disease of unknown etiology. There is flat top, itchy, violaceous lesions, histologically liquefactive degeneration of the basal layer. Typical lichen planus. Koebner phenomenon, which I told you is trauma-induced. Lichen planopilaris, also called as the follicular lichen planus, centered around the follicles and results in permanent or cicatricial scarring. Oral lichen planus, the typical lacy network. Lichen planus of nails, you can see the pterygium, which is the elongation continuation of the proximal nail fold to divide the nail plate into two halves triangularly. Then infections. Bacterial infections, viral infections, and fungal infections included in your syllabus. This is impetigo. The left one on our side is the clearer one is staphylococcus or the bullous impetigo, and the right one is streptococcal or the dirty looking honey crusted lesion with more scarring, perioral and periocular. Erysipelas is infection of the skin and subcutaneous tissue caused by Streptococcus haemolyticus. With the prodrome and morphology, it is sharply demarcated, unilateral. Cellulitis is often mistaken for erysipelas. It is the inflammation of the loose connective tissue, red hot tender, and bully suppuration and necrosis may be present. Then the left on our side is erysipelas and the one on the right, diffuse one is cellulitis. This is folliculitis, inflammation, superficial inflammation of the hair follicle, follicular opening. This is a picture of chickenpox or varicella. On our left is a child showing the centripetal distribution with polymorphic lesions. And on the right is enlargement magnified form showing the same thing. Herpes zoster showing the dermatomal distribution on the cervical, thoracic, and the lumbar region. Measles showing the complex spot in the oral cavity and the monomorphic lesion on the body of a child. On our left is herpes simplex labialis, showing the herpetic clustering of the small vesicles. On our right is pearly white lesions with central depressed punctum of molluscum contagiosum caused by molluscpox virus. Viral warts, the typical warts affecting the hands and feet, dirty looking. Then on our left is the fungal infection, pityriasis versicolor, which is a very mild type of fungal infection, affected, just causing hyperpigmented lesions with slight scaling, Rani scales. And on our right is the very typical itchy fungal infection, or the tinea corporis, called as the ringworm commonly. Tinea capitis, all 4 types of tinea capitis. Upper left is Kirion. Next to it is gray patch. Below it is the black dot, and on our left lowermost quadrant is the favus caused by trichophyton schondlini. Then on our left is candidiasis of the genital area. You can see the main lesion surrounded by satellite lesions. And on our right is the typical oral thrush, oral candidiasis seen in children often. Common drug eruptions. Erythema multiforme. Also, this is basically usually caused by herpes simplex, EBV, histoplasmosis. Targetoid lesions are present in that. Stevens-Johnson is also called as erythema multiforme major and may peak in the second decade. It may continue into toxic epidermal necrolysis, which is also called as Lyell syndrome. Most commonly occurs in women, elderly, and slow acetylators who cannot remove the medicine or any drug from their body quickly as other people do. And it occurs in immunocompromised. Mortality is 25 to 50%, almost always drug-related. Angioedema, increased intravascular permeability, well-circumscribed acute cutaneous edema due to increased intravascular permeability, face, lips, genitalia affected. It's not pruritic like urticaria, it's more painful, and it has more systemic involvement and can be fatal with abdominal pain and respiratory distress. This is fixed drug eruption. Then vesiculobullous disorders, vesicle is small and bulla is enlarged. Pemphigus vulgaris, autoantibodies against desmoglein 3, which are present over the desmosomes. Then predilection for scalp, face, exudative groins, and flaccid blisters, which are filled with clear fluid and become turbid and ruptured erosions. Nikolsky's sign is positive, which is firm sliding pressure, which separates the normal-looking epidermis from the affected epidermis and dermis. Bullous spreading sign or Aspo-Hensen sign is positive. Clinical features of this is bullous pemphigoid, urticaria or eczematous-like rash. Over this, the bulla develop, which are tense dome shape, because this has subepidermal bulla. The issue is in the hemidesmosomes. The overall generalized condition is good. This is a picture of bullous pemphigoid. These are the differences. Epidermolysis bullosa, butterfly disease in butterfly children. Rare group occurs in children. These are the sign symptoms: blistering, internal blistering, even affecting all the digestive, respiratory, urinary tract. Scarring alopecia, atrophic scarring of the skin, milia, dental abnormalities may be present. Lot of complications, even resulting in death. Then cutaneous manifestations of the internal diseases. These are the common systemic diseases with cutaneous manifestations. Necrobiosis, lipoidica, most common classical picture, present on the shins for diabetes, not painful. Acanthosis nigricans, hyperpigmented velvety plaques in the body folds. Diabetic dermopathy, most common shin spots, or the pigmented pretibial papules present, most common cutaneous manifestation of diabetes. No treatment is needed. Then scleromyxedema and hyperthyroidism, numerous form white, yellow, pink papules. Hypothyroidism with generalized myxedema. Then cutaneous manifestations of uremia, cirrhosis, pruritus, pigmentary changes, bullous disease, or dialysis. Uremic frost was more common in the pre-dialysis era, and the water evaporated, the sweat evaporated, and left the extra urea on the face because of dysfunctioning of the kidneys. Then Lindsay's nails or half and half nails. Chronic liver disease showing Palmer erythema, exaggerated mottling, gynecomastia. Malar erythema of the systemic lupus erythematosus, also called as butterfly rash, more common in young females. Then sexually transmitted diseases. What is a sexually transmitted disease? That are transmitted from person to person through intimate sexual contact. Maternal-fetal transmission is also there. Maternal-infant transmission is also there. Genital ulcer diseases, some present with ulcer. Ulcers can be painful and painless. Now, syphilis, primary lesion is a chancre, most commonly seen on the external genitalia in the females and males both. Lesions heal after 1 to 2 weeks. Swab of the chancre, when examined under dark field microscope, shows spirochetes and becomes positive 90% after 3 weeks. This is a lesion of the primary in the female and the male. Dark field microscopy shows the spirally arranged spirochetes, Treponema pallidum. This is a picture of gamma of tertiary syphilis, not commonly seen now because of early treatment possible. Then congenital syphilis with bone deformities, blindness, deafness, deformed faces, skin rashes, dental deformities. This is the most common congenital deformity of the nails of the teeth called as Hutchinson's incisor, which are with peg-shaped or barrel-shaped teeth. Then there are non-specific tests like VDRL, RPR, and ELISA. Then there are specific treponemal tests like treponema pallidum immobilization test, hemagglutination test, and FTA-ABS. Then chancroid, one or more red painful papules or pustules are present. These are painful, have ragged edges and sloughing bases, bleed easily on touch, and they're soft, non-indurated. And this is all is in comparison to that of chancre. This is a picture of the chancroid. And these are the differences between the chancroid and chancre. The good thing is that they all are easily treatable if diagnosed. And this is Neisseria gonorrhea, the last of all the sexually transmitted diseases caused by gram-negative diplococci. Male to female transmission is more. And in the females, the primary site is endocervix, which can lead to pelvic inflammatory disease and even disseminated gonococcal septicemia and infections like endocarditis, meningitis, and purulent arthritis. This is a picture showing typical purulent penile discharge. Now there's a small quiz time showing some of the pictures that you have seen. This is plaque psoriasis, right? Primary syphilis. These are the lesions. Diabetic dermopathy, you can judge yourself what it is. Uremic frost, end-stage renal disease with uremia, malar erythema of this SLE, then gonorrhea, the penile lesions, pemphigus vulgaris, all erosions, no intact blisters seen, epidermolysis bullosa, all the signs of epidermolysis bullosa, Stevens-Johnson syndrome, which is also called as erythema multiforme major.